Okay, so my topic today is the role of embryologists, what goes on in the IVF laboratory, and I will talk about the oocyte retrieval, IVF, and egg laying. Now, as you know, since the birth of Louis Brown in 1978, clinical embryology was recognized as a medical laboratory-based specialty or profession. And our first embryologist, Sir Robert Geoffrey Evarts, who won the Nobel Prize a few years ago. Yeah. Now, as you know, in the menstrual cycle, as you know, a woman is born with about limited number of eggs, probably around 1 to 2 million eggs when she was born, and around puberty, she will have lost half the number of eggs. Yeah. Now, just to make you understand why we in embryology, in IVF, we grow the embryos to the blastocyst. So just to let you know about the natural way. So now when the oocyte is ovulated and the sperm is deposited in the vagina, what happens is that the sperm will swim all the way through the cervix to the uterus and to the fallopian tube, and fertilization happens within the tube. Now, once the egg has been fertilized, it's known as an embryo, and this little embryo will need to travel down the tube to reach the uterus. So it takes about 5 days for the embryo to reach it, and during the 5-day journey, it grows more and more cells. And by the time it reaches the uterus, it has reached a very specialized embryo known as the blastocyst. And that's when this embryo will implant and hopefully result in a live birth. Now, just to share with you a video, just to let you know how egg collection is being done.
A needle is attached to the vaginal ultrasound probe. Both are introduced into the vagina. Under ultrasound guidance, the needle is inserted through the vaginal wall towards the ovary and is introduced into one of the follicles. The content of the follicle is aspired and is passed through a closed circuit of tubes to the test tube. This test tube will be analyzed by a biologist to separate the ovum from the follicular liquid. Once aspiration of the follicle is finished, the needle is inserted into the next follicle, which is then aspirated. This process is repeated until all the follicles have been aspirated.
Okay, now what happens is that once the egg has been collected, they'll be washed, rinsed, and then put in incubator for about 2 to 3 hours before they're ready for insemination. So now, basically in IVF, what happens is that the eggs and the sperm will mix together to allow the sperm to penetrate the cumulus cells. The cumulus cells are the cells that nourish the egg, as well as important for sperm selection. Once the sperm has gone through the cumulus cells, it will reach the zona pellucida, is the eggshell, and the sperm then undergo acrosome reaction, whereby the acrosin is released, which is an enzyme which helps the embryo and will help the sperm to drill a tunnel through before it goes in and fertilizes the egg. Now, fertilization happens when the sperm a membrane is fused with the egg, and then the sperm will deposit a protein that is responsible for activation of the egg and fertilization. And this important protein is commonly known as PLC zeta, and from there the sperm will the fertilization process will happen. Now, not every sperm can fertilize the egg, so there are limitations like azoospermia or severe oligoteratoestenozoospermia. That means poor sperm count, poor morphology, or poor motility, and sometimes even with very thick zona pellucida or thick shell, thick and compact, that the sperm is unable to penetrate the eggshell and fertilize the egg, or as a result of poor sperm-egg binding. Now, what happens in this situation? So in this situation, IVF success will be very low and fail. So what's the next step? So the next step, of course, I'm going to give you a historical perspective, how what we call micro-assisted fertilization. So the first attempt at micro-assisted fertilization was, the methodology was partial zonal dissection, which was developed by Cohen in 1988. Now, what happens is that you have a sharp needle here, and the zona pellucida is pierced through to create holes or tunnels to allow the sperm to swim in and fertilize the egg. So in other words, this egg, the zona has been punctured and mixed with the sperm. But there's also a limitation here, because only sperm with good sperm count, more than 20 million, and with good motility and forward progression can fertilize the egg. And the success rate for this PZD is to me is a bit less, and probably is about 10 to 20%. Yeah, and a lot of those men who have poor sperm qualities, poor sperm count, will not have difficulty fathering a child using this method. So the next method developed was SUSI. SUSI means inserting instead of creating holes, the sperm, a few sperm between 5 and 10 motile sperm were deposited within the peritoneal space, the space that is between the eggshell and the egg. And the idea is to allow at least one sperm to fertilize the egg, to fuse with the egg and fertilize the egg. But the problem with this one, yes, it has given some success, and the success is also less than 20%. The limitation is because those sperm that have low sperm count and poor sperm morphology is unable to fertilize the egg. Yeah, and also the risk of polyspermy. It could be more than one sperm fertilizing the egg. Then again, because in those days, people would think that you can't inject the sperm directly into the egg, because if you were to do that, you're going to kill the egg. So the next step, somehow, I think by accident, because of the SUSI, one of the sperm entered into the egg and fertilized the egg. And that's how intracytoplasmic sperm injection was developed, and pregnancies have been reported by Palermo in 1992. And this technique has revolutionized the whole treatment for male infertility, the severe male infertility. The only limitation during that time was non-viable sperm. In other words, as long as the sperm is viable, it can can fertilize the egg, it can produce an embryo, and it has the potential to generate a pregnancy. Now, what are the implications for ICSI? So now, because as I mentioned, it has revolutionized treatment of male infertility. So the indication for ICSI can be azoospermia, whereby there's no sperm present in the ejaculate. So as due to obstructive or non-obstructive azoospermia, or a sperm can be extracted from the epididymis or testicle, and sperm can be used to fertilize the egg and generate a live birth. Even immature sperm, particularly elongating and round spermatids, pregnancy and live births have been reported. With severe odds, like very severe low sperm count, near azoospermia, and even those non-motile sperm, like conditions like Cartagena syndrome or sperm lacking acrosome, which are unable to fertilize the egg naturally. ICSI can help in this situation. Now, ICSI can also be commonly used now for non-male factor, like those eggs with thick zona. Now you can use ICSI to generate a live birth or pregnancy. Poor sperm egg binding, particularly is found in IVF, then you can convert it to ICSI. Warm oocytes, meaning autologous or donor oocytes. IBM oocytes, and those are going for PGT or pre-implantation genetic testing, and those women we could only recover a few eggs. And to ensure that the eggs are fertilized, all the eggs are fertilized, ICSI is being used. Now, how is ICSI done? First of all, the tools of our ICSI or micromanipulation system. Now, this micromanipulation system consists of a high powerful inverted microscopes, and it has two arms of what they call micromanipulation arms, one for holding the egg, the other one for selecting the sperm and injecting the sperm into the egg. And these are the micro injectors and the joysticks that control the movement, course and fine movement of manipulating the eggs and injecting the sperm into the egg. Now, as I mentioned earlier, first reported ICSI pregnancies and live birth in 1992. Now, as I mentioned also, just to summarize, ICSI is an effective treatment for male infertility, and as long as sperm is viable, fertilization and pregnancy can occur. Now, how do we prepare sperm for ICSI? First of all, when you collect the eggs at COC and we prepare the sperm for ICSI, you have to remove the cumulus cells surrounding the egg. So what you have to do is to expose the COC in a droplet of hyaluronidase, an enzyme that separate the cumulus cells from the egg. And then what you need to do is to do manual denuding, whereby the eggs is manipulated in a series of tubes or pipettes in different sizes to remove as much of the cells as possible from the egg. And after that, the denuded egg is then rinsed in the culture medium and then Hippe's buffer medium, and then later on put into a culture medium and put in incubator, and then rest it for a few minutes before ICSI begins. Now, during the denuding process, the operator, the embryologist, can also visualize the maturity of the eggs. Now, just for your information, not every egg collected from the egg collection is mature. Hopefully, at least 80% of the eggs are mature. And some of these immature eggs can be like a germinal vesicle. You can see a germinal vesicle in the egg. It's very immature, or metaphase 1 and metaphase 2. The mature eggs, all the eggs are rested at metaphase 2. And these are the eggs that can be used for fertilization. Now, how do we prepare the dish for fertilization? This is like an example for the injection dish. What you see here, these are the true droplets for the sperm suspension. After the sperm has been prepared, the sperm suspension is placed here. And this is a droplet, what we call a PVP droplet. It's a viscous solution that when the sperm is placed here, the sperm is slowed down and easy for manipulation and selection. And once the sperm has been selected, and this is where the eggs are in each individual droplet, and ICSI is done within this droplet. Now, this is just to show you an example, a picture here, where this is the sperm suspension. The sperm would like to go, like to swim along the margin of the droplet. And what you need to do is just aspirate a few of this sperm and place it in the PVP. And from there, you can select and manipulate the sperm. Now, one important step for ICSI is immobilization of the sperm. Why? Because it is very mandatory, even with totally immortal sperm, but a viable sperm. So what happens is that now the embryologist will use the needle, the pipette, to crush the tail. By crushing the tail, it creates damage to the injured area, and the cytosolic factor will leak through that when it's injected into the egg. This cytosolic factor will leak into the cytoplasm, and this cytoplasm will activate the egg and help the egg to release the intracellular calcium and generate oocyte activation. All right. Now, the oocyte activation serves two important purposes. One is the resumption of meiosis in oocyte to complete the meiosis, so that pronuclear formation from the egg is attained. And the other aspect is to allow to decondensation of the sperm head nucleus, and from there generate a male pronucleus. Now, how do we inject the sperm in? Now, what we need to do is that when you prepare the sperm for injection, you have to suck the sperm tail in first. The reason being is that when you do the injection, you deposit the sperm and the midpiece go into the egg first. Now, sperm, nucleus, the head, and the tail and the midpiece are important. The tail is not important. So most important is this aspect, the sperm and the egg. Yeah, this is to ensure that the sperm head and the midpiece are deposited in the egg cytoplasm. Now, another aspect is that how do we orientate the egg for my injection? Now, what happens is here, this is the normal egg, you can see. Now, what is most important is the orientation. I'm sure those who have done ICSI, you'll be told that to orientate the first polar body at 12 o'clock or 6 o'clock position. Why? Because of the presence of the meiotic spindle is usually found adjacent to the first polar body. All right. Now, during ICSI, microinjection needle should avoid damage to the meiotic spindle, because if the meiotic spindle is damaged, then the egg will lyse. So this is just to show you here the presence of the meiotic spindle at 12 o'clock adjacent to it, or at 6 o'clock. This is adjacent to it. So injection is done at 3 o'clock position to avoid damaging the meiotic spindle. Now, what's the process like? First of all, when you do the injection, you have to break the membrane. So what happens is that the needle should go in, and it seems that the needle has penetrated into the egg, but it's not true. The egg membrane is not broken. So what you need to do is that you aspirate the membrane to make sure that the membrane is broken, and you see a sudden movement of the sperm back into the needle. And then after that, you just deposit the sperm into the cytoplasm. And during this process, suction and depositing of the sperm into it, it also initiates activation and oocyte activation and initiation of the fertilization process. And sperm should be properly gently displaced into oocyte, and the needle should be gently removed from the egg. Now, after the ICSI, then the injected eggs will go through a series of IVF medium to rinse it from the TP's buffer medium, and then it's cultured either in droplet 1 or droplet 2. And 14 to 16 hours after sperm injection, then fertilization is checked, and after that, the fertilized eggs are transferred to the next culture medium and to allow it to grow to day 3 or day 5 embryo for transfer. Now, what are the possible failure of ICSI? One of the possible ones are the induction of calcium oscillations in the human sperm. And now the sperm, as I said, is the cytosolic factor. The presence of a cytosolic factor in the sperm is important, or the quantity itself is important for generating oocyte activation. But there are some sperm that does not have a sufficient quantity of the cytosolic factor, or none at all, that oocyte activation cannot happen, and fertilization can fail because of that. Yeah. Now, this important protein, PLC-zeta, a sperm oocyte activating factor. Now, some sperm may have mutation in this important protein. All right. Now, this is the normal. They generate good oocyte activation. The defective ones is this. There's a mutation here. So sometimes you wonder, this man has very good sperm, good morphology, but fertilization failure. Fertilization failed by good eggs and everything. Why? It's possible that the sperm had a mutation in this activating factor protein here. Now, oocyte activation, one of the prospects is, well, how can you overcome that? So we use oocyte activation. So this is just a general principle. Now, in IVF itself, what happens is that the sperm, as I mentioned, fuses with the egg membrane, and from there, it releases the PLC zeta, and this go in and activate the oocyte vesicle, release intracellular calcium, and with the release of intracellular calcium, it activates the whole fertilization process in the egg. Now, what are the methods of assisted oocyte activation? It can be mechanical, by the action of injection or injecting calcium chloride into it, or by electrical activation by pulsing the egg in a series of current, or by chemical activation using calcium ionophore or ionomycin. But the most preferred method will be calcium ionophore, and it's the safest. Now, just to give you a summary of how the oocyte retrieval and ICSI and IVF is prepared. So during the oocyte retrieval, COC is recovered, and this COC is then placed in incubator and rests for about 3 to 4 hours. And and then during that time, the sperm are prepared. And if it's for IVF, then the sperm are inseminated with the COC and allow IVF fertilization to happen. If it's for ICSI, then the eggs are denuded, and then eggs are selected, metaphase 2 eggs, and then injected, and then grow in the incubator. Now, contributions of the ART laboratory. So as all of you know, the lab plays a very important part in IVF, and it contributes as much as 70% of the success rate in IVF treatment. So the major responsibility as an embryologist is to not only effect fertilization, excuse me, and also to ensure optimal development of the pre-implantation embryos, and consequently a healthy, viable pregnancy. Now, the role of the embryologist also to ensure and evaluate, characterize, prepare, and process samples, provide an optimal environment for fertilization, the embryo development, and an effective substitute in the lab itself is an effective substitute for a human organ, the fallopian tube. So the role of the embryologist is to make sure that the conditions are all conducive for embryo development and fertilization. So embryologists provide scientific and technical expertise, as I mentioned earlier, optimal embryo culture environment, and technical procedures to facilitate fertilization, embryo development, implantation, and finally. So in conclusion, since the birth of Louis Brown, the role of the clinical embryologist has evolved to a highly skilled artisan of life, who is extensively trained to master sensitive microscale procedures where the risk of error is almost nil. From a laboratory technician skilled in IVF in the 80s and 90s to a highly respected professional clinical embryologist in the 20th century. So clinical embryologist is a highly rewarding profession and career. Work very closely with patients, doctors, nurses, and other medical professionals with the objective of giving the best outcome for the patients. So over here, we have a holistic approach to IVF, and this is the IVF couple. So we work very closely with a team of clinicians, nurses, fertility coach, which deal with emotional aspect of the patient, and our management supporting staff. to give a very ideal environment for the couple and give them the best treatment for IVF. I'd like to share, and before I close, I'd like to share the process again, how our lab will do the IVF. Yeah? So that's the end of my presentation. Thank you very much.
In this second part of module, let's discuss the role of embryologists, what we do for the embryo culture and embryo transfer procedures. We'll discuss the lab workflow and key elements first, then we'll touch base about a general idea of the embryo culture and the areas we have to pay attention to. Then the lab perspective of embryo transfer. This is a day life in the IVF lab. Our incubator, we do the ICSI. Then for the embryo culture and handling, we have micropipette, and the embryologists use a micropipette to handle the embryos in the drop. and the dish covered by the oil. And we culture the embryos in the benchtop incubators as well as in the time-lapse incubator. This is the video of the time-lapse. You can see the morula forming and the early cavitation, very early blastocyst, then form the full blastocyst. For good quality embryos, we will freeze those for future use, especially in the freeze-all strategy nowadays commonly used in many procedures. We'll put the embryos into a liquid nitrogen for long-term cryopreservation. Also, we get those daily questions from clinicians and nurses, like how many oocytes were fertilized? How do embryo look like today? How many good embryos does this patient have? And also, we may be told to just pick the best embryo to thaw and transfer. Then, which one is actually the best embryo? And what does grade 4AB blastocyst mean, or other grade of the embryo? Those questions, as well as could you call the patient and explain more about the embryo quality? And this is the IVF lab workflow. I'm not going to go through every detail of each step. Just want to demonstrate that it's a very complicated process and involve a lot of quality control, and we pay attention to details in all the steps. The key elements in the IVF lab. We have a sperm oocyte, then we fertilize the oocyte with either conventional insemination or ICSI with the sperm, and we culture the embryos in the incubators. We call the culture system, which involve the oil overlay, gas phase, and the plastic ware and the contact supplies. Culture medium, very important component, and also how many embryos we put into each drop. Besides the incubators, we have to pay attention to the air quality as well as the training level and the competency of embryologists. We have a lab director, supervisor, embryologists, embryologists, endocrine tech, as well as a lab and research assistant to form a great lab team to provide the best patient service. After we culture embryo, those embryos can be used for the transfer or frozen or sent to the PGT for the genetic testing. We perform very extensive QC and QA on all aspects of the laboratory, from the embryo culture, transfer to PGT, all those efforts, and we hope we can contribute to best outcomes for the patient. Let's talk about the embryo culture. So after the fertilization, we'll put the embryos back to the incubator. Then we start counting from day 0. So day 1, post the fertilization, we'll do the fertilization check. Ideally, we would like to see 2 pronuclei. That's normal fertilization. And by the end of day 1, the embryo should be at 2-cell stage. And on day 2, ideally, the embryo should form a 4-cell. And on day 3, in most cases, the 7 to 9 cell embryo is suitable for embryo transfer if we choose to transfer on day 3. Also on day 3, the embryo will initiate the compaction and gradually becoming a morula on day 4. During the first 4 days, we will monitor the cell number. Each cell of the embryo is called blastomere. We will monitor the blastomere number, the symmetry of the embryo, and also the fragmentation. 10% or 11 to 25% or more than 25% of the embryo are fragmented. For the 10% or lower fragmentation, which would be considered mild and a good quality embryo. Also, we will note any additional characteristics, any like a debris or unique characteristic of the specific embryo. Then on day 5 to 7, the embryos enters the blastocyst stage. From the early blastocyst to hatch the blastocyst, we often call those blastocysts just blast. We use the alphanumeric Gardner and Schoolcraft grading system for the blastocyst grading. For example, like a 4AB. So 3 parts. The first part is the blastocele cavity and expansion of the embryo. That would be grade 1 through grade 6. Grade 1, early blast, less than 50% cavity. And grade 2 is the embryo with a higher than 50% cavity in the blastocele. Grade 3 is a full blastocyst. Grade 4 is expanded blastocyst. Grade 5 is hatching blastocyst. The embryo is hatching out from the zona pellucida. And grade 6 means the embryo, the blastocyst, is fully hatched from the zona. Also, the second and third part of the grading system indicates the quality of the inner cell mass, which will become the fetus in the future, as well as the trophectoderm, which will become the fetal part of a placenta in the future. So here is a chapter we wrote in this very nice book, Principles of IVF Lab Practice. The second edition is upcoming this year, so I encourage everybody to take time to read either the first edition or the upcoming second edition. So blastocyst development, the early blastocyst, it could be less or more than 50% of the cavity inside. And full blastocyst, we have a well-defined like a trophectoderm and also the ICM. ICM is compact. And expanded blastocyst, grade 4, 5, or 6. Note the zona is thinner, and there's a good like a cohesive mural layer of the trophectoderm and a compacted inner cell mass. And of course, those are standard morphology of the embryos. Other than those, we see all kind of different looking embryos in the lab. Some of them are good, some of them are very like a poor quality like this one. Some of them look good, but if we run a PGT, like for example, like this one, it actually was aneuploid. And this one, it looks very strange. It's like a cigar shape. However, actually it end up with a good outcome. The key factors, and also those factors we can use for troubleshooting in the IVF lab, involve those different criteria. And I circle those which is more related to the embryo culture. The quality control, the IVF culture system, including the incubator, osmolarity, of the culture medium, pH of the medium, and temperature, and light in the lab. Also the gas supply into the incubator to control the pH. For example, we use the CO2 to control the pH, and also we use nitrogen to control a low oxygen environment inside the incubator. And also infections, we want to minimize the infection as much as possible. One of the key factors in the IVF lab is incubators. Some labs may still use the traditional big box incubators. A majority of the modern era IVF labs utilize those benchtop incubators. Some of them are dry setting, some of them are humidified. And here are the different types of the time-lapse incubators. So time-lapse imaging has become more popular and also become very useful tool for the IVF lab. Another important topic and also commonly discussed is the culture medium. So the lab people often talk about sequential medium, single-step medium, and also they will compare different brands or different type of medium. So the major types of culture medium can be divided into sequential and the single-step. Sequential means we have two types of culture medium to use to culture the embryo from day 0 to day 7, up to day 7. In most cases, we use one type of the medium during the first 3 days or 4 days. Then we switch it to another set of maybe the same brand of the medium or different company. And ideally, it's recommended to stay like with the same company if you choose a sequential medium. So embryos are moved from the first type of the medium to the second stage of the culture medium. Oftentimes, we will use a new culture dish to prepare the second set of the medium, then move the embryo over. For single-step medium, which we use only one type of the medium throughout all 7 days, whether we may replenish the medium every 2 to 3 days, so we may move embryo from one dish to the new dish, the second dish, with the same medium, or in many cases nowadays, we just continue culture the embryo in the same drop, in the same dish throughout the 7 days. They have pros and cons with each type of medium. And things to consider when we select the embryo culture medium include if they can support the embryo growth throughout the culture period. Some medium may work better in one lab, and another type of medium may work better in another lab. So the lab has to test and decide and validate and decide which culture system and which medium is best fit for the lab. And also the medium should minimize the metabolic stress to the embryo. And also it should be easy to use. This is a very basic concept about comparing a sequential culture system and the single-step culture. For sequential, the idea is the embryo might need different nutrients and also at different level, different concentration at the pre-compaction, the first 3 days, and also the post-compaction, the stage after the day 3. For those 2 stages, the embryo might need different components. And for single-step culture, the design is to provide enough nutrients in the medium and let the embryo pick up which one it decides to absorb and utilize. After we culture the embryo for a few days, we can select those for transfer, either for fresh cycles or the frozen embryo transfer cycles. The fresh embryo transfer usually happens on day 3 or day 5, and nowadays the day 5 blastocyst transfer are more common. And the embryologist, the communication with the clinician and nurses is very important, especially when it comes to the patient identification, the embryo identification, and the number of embryos to use. The witnessing and also identification are very important. Witnessing can be done through manually, by a second person in the lab or outside the lab, or nowadays there are electronic witnessing systems to help the lab. And the gut blastocyst usually is categorized as grade 3 or above. Ideally, we want a grade 4 or 5. And ICM trophectoderm quality is a BB or above. Ideally, we will prefer the AA, also the euploid embryos. One of the hot topic is if the embryo is not euploid, if they are mosaic after the PGT testing, should we transfer them? There are research talking about the transferring low and high mosaic embryos, and it could possibly form a healthy live birth. However, the consent with the patient and also communication with the patient about the risk is very important. For the embryo culture, selection, and transfer, in the lab, we track and evaluate all the outcomes, and we monitor the data, and we utilize the KPI to see how well we're performing compared to other labs. So this is a diagram about when we culture embryo, how we select the embryo for different purposes, the best and also normal embryos, if the embryo goes through the PGT, will be used for embryo transfer, either fresh or the primary FET in the freeze-all strategy. And the other normal embryos will be used for cryopreservation and upcoming FET. And abnormal embryos, there's no way to repair and reconstruct those embryos nowadays. So we probably just discard them. In the future, maybe with the gene editing technology or stem cell therapy, we can rescue those embryos and make them useful. Again, as I mentioned earlier, the PGT-A mosaic embryo transfer, the utilization of those mosaic embryos is very hot topic now. When we select the good quality embryo for transfer, the lab will prepare for the embryo transfer fresh or thaw the frozen embryos for the transfer. How many embryos should we transfer? That's a very critical decision which should be made among the patient and clinician with a recommendation from the lab. The SRM has a guideline regarding how many embryos to transfer for different age group and their prognosis. Nowadays, it's recommended to do as much single embryo transfer as we could. The purpose of the single embryo transfer is to minimize the multiple gestation. So we will only have one single healthy live birth. And that's the goal, the ideal goal for each treatment cycle. So single embryo transfer is recommended for most cases. The communication with the clinician, nurses, and the patient is very important. Which embryos to transfer and whether we do the single embryo transfer or in some cases, maybe transfer 2 embryos. And the workflow, when we decide like how many embryos to transfer, then the lab will set a timeline, and we sow the embryo for FET, or we have to discuss what to do with the other embryos after we transfer the one we want for the fresh transfer. So either we can do the like a cryo, like freeze the rest of the cohort, or discard if the PGT outcome comes back as aneuploidy, or discuss with the patient about the mosaic embryos, or even some patients might choose to keep the aneuploid embryos in the cryo storage. For the embryo transfer, the specimen identification and verification is very important. We want to make sure the correct embryo is being transferred to the correct patient. The lab often have the checklist to verify those. So we go through the steps and we sign our names on those to make sure everybody's done their work. Also, there's a surgical pause before the final transfer into the patient. So we load the embryos into AC catheter, then we pass to the clinician, and we will have the final surgical pause to make sure that the patient identification is correct. For the embryo culture and the transfer, there's a lot of documentation and quality management involved, and those are very crucial in the IVF lab. We record all the procedures and outcomes accurately and completely. We ensure the proper patient identification and traceability and QC is performed. We monitor and evaluate those procedures and outcome data, and also we minimize errors and optimize the patient service. The commonly used document, including all those, a lot of paperwork we have to do. And in many labs, some embryologists, they may spend more than half of their work hours working on the paperwork. So those are few examples of the paperwork we're performing, like a daily startup and shutdown checklist and all the equipment. And we check the liquid nitrogen tank to make sure the label is good, the temperature is good, so the cryopreserved embryos or oocytes or sperm, the specimen, are in good hands. We will run the pH testing on the medium to make sure the CO2, the gas, is controlled within the range, aiming for the ideal pH value. And we also have some sign-in sheet, like the nurses will pass the specimen to us and they have to sign in, we have to verify, and the lab also log in to make sure the chain of custody. We have a checklist, like I mentioned, the surgical pause is very important. Make sure the correct patient, the correct embryo, and also all the information has been verified. When we have all those data, we monitor and evaluate those data, we run the QA/QC to see if there's a change of the trend, like a sudden change of the trend, or like a shift, like a long-term shift of the outcomes or the equipment conditions. And oftentimes we have more than 2 or 3 variables in the lab involved into the same procedure. So things could get very complicated. And one of the important things, and oftentimes the time-consuming task, is for the embryologist in the lab to figure out which factor or which condition actually changed and have the biggest impact. Then we correct that and we minimize the non-conformance. When we have all those data, we can run those data utilizing the key performance indicator, and we can use those data to measure against the outside organizations or published benchmarking. The Vienna consensus have the KPI and also the competency and benchmark values. Here is an example of the Vienna consensus, the reference indicators, which there's nothing the lab can control. Those are the responses to the ovarian stimulation. And there are performance indicators, the documented and stored information, but may not be reported. I want to point out that good blood cell cyst development rate, it used to be performance indicators, and nowadays there are more and more labs utilizing those as a good like a KPI, the key performance indicators. Because if you have two labs, they have the same percentage of blood cell cyst development rate. One has a higher good blood cell rate, the other one has a lower blood cell rate. Then the one with good blood cell rate probably have a better culture condition and the protocol. And here are 12 KPIs listed by Vienna consensus. Those are relevant to the embryo culture and transfer. Also, I want to point out that many labs nowadays don't check the cleavage stage embryo development, because we will keep the incubator closed for 5 days. Then we check the blood cell cyst. The prerequisite of that practice is the good culture condition. So we know that for a standard and at least a decent prognosis patient, we should have a very high percentage of blood cell cyst. And the blood cell cyst cryo survival rate and also the implantation rate, those are KPI utilized by the Vienna consensus. For further reading, I will recommend those couple guidelines and papers to start with. And last year we published this article, The Common Practices Among Consistently High-Performing In Vitro Fertilization Programs in the United States. It's a 10-year update from the previous version. It discusses about how those high-performing IVF programs utilize the KPI and also what the practice they do for the clinical and the lab size. And also the principle of the IVF lab practice, which I mentioned earlier in one of the slides. The second edition is upcoming in 2023. It's a very good source with concise and easy to understand short chapters covering all aspects of IVF lab practice. I want to say that good quality lab make happy blood cell cysts and good outcomes, and that's the ultimate goal we would like for our patient service. And thank you all. And we will move to the part 3 of this module and followed by a Q&A section.
Hello, everyone. Welcome to Aspire webinar, to the series, What Goes On in the IVF Laboratory. I would like to talk about cryopreservation. My name is Atsushi Tanaka. I'm director of the St. Mother Clinic in Japan. The advanced technology of cryopreservation for ART has been contributing to rescue many childless couples. I'd like to talk about status updates. This is the content of today's presentation. There are 4 topics. I'd like to mention them in this order. This shows the numbers of cycles by ART procedure in 2020 in Japan. Total cycles were about 450,000 and FET cycles were 215,000. It's about half of total cycles. This shows the numbers of births for each ART procedure. Surprisingly, the proportion of FET was 91.9%. From these results, the policy of ART in Japan is freeze all. But it doesn't mean to freeze all cleaved embryos, but freezes only all viable embryos after oocyte collection and transfer them during the next cycle. So vitrification is widely used and known, but what is vitrification? So vitrification is a process of freezing so rapidly that the water molecules in the oocytes or embryos do not have time to form ice crystals and instead instantly solidify into a glass-like structure. And watch induced vitrification. There are 2 points. First is rapid cooling and rapid warming through glass transition. Second is chemical reaction with application of cryoprotectant and anti-freezing substance. This shows the differences of two groups. As you can see, the only procedure of equilibration is different. Embryo has 1 step, while oocyte, 3 steps. It takes more time for oocyte equilibration and carefulness due to more fragility of unfertilized oocyte. The remaining procedures are the same. Cryopreservation of blood cyst. Vitrification media is equivalent solution, has ethylene glycol 7%, DMSO 7%. Vitrification solution has ethylene glycol 14.5%, DMSO 14.5%, trehalose 0.5 molar, respectively. Prepare the cryoprotectant ESVS. It's before cryopreservation, beautiful blood cysts. Move to ES. Start the shrinkage of inner cells, and it's after 50 minutes, and returning to the original size. Move to VS1. Move to VS1. Stir the VS1 around the embryo at various sites. Move to VS2. Stir the VS2 for 30 seconds. Put the embryo on the cryo top. Remove excessive VS2. This is the process after removal of VS2. This slide shows the crucial point of freezing. In short, remove the excess VS on the cryo top as little as it possible. Long time in VS is detrimental for both of oocyte and embryo. Place the pipette, the VS to drop, and slide the pipette horizontally and aspirate the excess VS and minimize the VS drop. Left group is good example. Right group is bad example. Obviously, there are large volume of VS on the right group. Plunge into the liquid nitrogen and insert the cryotop sheet into the straw cap. Next step is the thawing. Thawing media is a thawing solution, Tehalose 1 molar, diluted solution, Tehalose 0.5 molar, and washing solution modified M199 with HEPAS buffer, respectively. Put the straw from the liquid nitrogen and remove the straw cap. Move to TS with 1 second. Blood sisters separated easily from the surface of the cryotop in the TS. Collect the embryo. Move to DS from TS. Move to DS from TS. Keep it in the DS for 3 minutes. Move to WS1. It's a recovering embryo in WS1 for 5 minutes. Move to WS2. It's recovering even more in WS2 for 1 minute. Move to culture medium. It's processed after cryopreservation. It's very beautiful, isn't it? This shows the survival rate of frozen blood cysts by 4 each groups after cryotop method. You can see that all of 4 institutes shows 95% of survival rate. And this is a clinical pregnancy for each institute. It shows frozen embryo transfer has significantly higher success rate than freeze embryo transfer under 34 years old patient group. And it's also the same trends between 35 and 39 years old group. And also it's the same over 40 years old patients. So next is oocyte. So unfertilized oocyte cultivation indication are oocyte donation and future use, because after treatment of cancer, and which is most commonly reason is delayed maternity due to carrier demands and lack of partner. Next is cryopreservation of oocytes. Vitrification media has a basic solution modified M199 with HEPAS buffer, and equilibration solution with ethylene glycol 7%, DMSO 7%. And vitrification solution has ethylene glycol 14.5% and DMSO 14.5%, respectively. Prepare BS, BS1, and BS2 in the well. It's before freezing. Move the oocyte into the BS. Add 20 microliter of ES to the BS slowly from outside. Slowly, gradually, and oocyte shrinks once and then returns to normal condition. Add 20 microliter or more of ES. Oocyte returning to normal size. Add another 240 microliter of ES. Oocyte completely returns to initial condition. Move to VS1. Move to BS2 and stir the solution. Stirs the medium and aspirate the oocyte and put the another side and repeat it the same procedure. Oocyte shrinks in the BS2. Put oocyte on the cryo top. Remove excessive VS. Plunge into the liquid nitrogen and insert the cryo top sheet into the straw cap. Next step is sewing. Sewing media has TS sewing solution, Telos 1 molar, diluted solution, Telos 0.5 molar, and washing solution modified M199 with herpes buffer. Prepare DS washing solution 1, 2 in the well. Put the straw from the liquid nitrogen and remove the straw cap. Move to TS within 1 second. Just after sewing, collect the separated oocyte. Move to WS1 from TS. Return to initial condition after shrinkage. Move from WS1 to WS2. Return to initial condition after shrinkage. Move to culture medium. It's after sewing, it will return to normal condition. And next is a PSXC with recent technique PSO. Injection pipette is penetrated the zona pellucida without a dent of zona pellucida and break the cytoplasm with a weak piezo pulse. This shows embryo development after ICSI, and you can see it's very beautiful development. This showed quick outcome of breast cyst from frozen oocyte transfer. So data from Stoke clinic in Taiwan. So surprising rebirth rate is 61.0%. Next is the sponsored cryopreservation. And first is a normal sperm condition. First is Pacol density gradient method. The sample is 20 minutes after ejaculation. It's liquefied completely. 5 set tubes with different concentration of Pacol solutions are prepared. Aspirate 1 milliliter of Pacol and stack them in order of heavy density. Now pour the Pacol alongside the tube. You can see clear 3 interfaces. This appearance of 3 lines shows successful lay of Pacol solution with a different gravity. Aspirate liquefied semen and ovary on the Pacol solutions and centrifuge with 1,300 RPM for 30 minutes. Discard the supernatant and resuspend remaining pellet and centrifuges with medium and aspirate the pellet. And mix it and supply for IVF. You can see the sperm condition became much clearer and higher movement after this procedure. Next is the swim up method. After centrifugation of liquefied sperm with medium, discard supernatant and the pellet at the bottom is mixed and put it carefully on the bottom of medium. Then incline the test tube at a 30-degree angle and put it in the incubator for 30 minutes. Aspirate supernatant and use for IVF. All of debris and dead sperms are not found. It became high quality sperms. Next is conservation of sperm. Collected high quality sperms with Pascal density gradient method and swimmer method are injected into the cryotube after mixing with cryoprotectant of ETCG and put in the cryotube and put in the vapor of liquid nitrogen for 30 minutes. And plunge it into a liquid nitrogen. Then stock in the tank. Condition after sowing is the same as that of before condition. Next is the single spermatozoon preservation. So cryopreservation of a single spermatozoon is indicated for cryptospermia and testicular sperm acquired after microtese for non-obstructive azoospermia. Next is cryopreservation for 3 testicular spermatozoa from non-obstructive azoospermia and cryptospermia. This is a view of the microtese in operation room. We made incision on the tunica albuginea. We tried to find thickened coiled seminiferous tubes which are likely to contain spermatozoa or spermatids. I picked it up under microscope. Biopsy tissues were methylated with a fine needle manually in a microdrop of medium. Specimens are observed under an inverted microscope. You can find a moving testicular sperm here, and this is a 1 to 3 spermatozoa from the patient cryptospermia. The sperms are aspirated into the aspiration pipette, tail first. This is the most important technique. Tail first, okay? This is the last third sperm aspirate from the tail. So you can see the 3 moving sperms in the aspiration pipette. The 3 sperms in the aspiration pipette move to a droplet of a freezing medium on the cryotop. We focus on the tip of the cryotop and align it with the tip of the pipette. Now you can see the 3 sperms moving in the freezing medium. The sperm is frozen in liquid nitrogen vapor and stored in liquid nitrogen. On the day of oocyte retrieval, the frozen sperm is dipped into droplet medium. You can see that the 3 sperms are moving after thawing, and they are ready to be used for ICSI. This shows the important parts of this method, okay? This is aspiration of 3 sponzoa, tail first, not tail, head first. This is a very important point. And next is preparation of 3 sponzoa. So tail first. So now you can see here the 3 sponzoa and the pipette. And now you can see the 3 sperm are injected into the medium. The last is ovarian tissues. Cryopreservation of ovarian tissue with slow chlorine. Cryoprotectant is DMSO on the human semen. So its ratio of human serum and 10% DMSO is 1:1. Slice human ovarian tissues into 1 millimeter pieces. Place 1 piece of ovarian tissue in 100 milliliters of cryoprotectant for 25 minutes. Immerse the tissue in cold water at 4 degrees Celsius for 5 minutes. Move it to cold water at 0 degrees Celsius for 5 minutes. Move it to methanol bath at -7 degrees Celsius, cooling at the speed of -0.3 degrees Celsius per minute to -30 degrees Celsius. And plunge it into liquid nitrogen. Next step is thawing. Soak the tissue into warm water at 37 degrees Celsius for 1 minute. It's put on the warm plate. Move to a micro drop of 10% SPS with modified HTF for 10 minutes for a recovery. This shows the slow freezing ovary. It's before condition. You can see most of oocytes are intact, and glandular cells tightly attached with oocytes. It's after freezing and the thawing slide. You can see most of oocyte, but a little fewer are returned to normal condition, and the glandular cell tightly attached with oocytes. In conclusion, first, cryopreservation of oocyte and embryo using vitrification has been established, and the clinical application has contributed to higher success rate. Second, sperm preservation with each concentration are established. Cryopreservation of single sperm using vitrification is very useful and is expected to use widely through ALT. Lastly, cryopreservation of ovarian tissue has not yet been established methodologically, slow freezing or vitrification. But the study is indispensable for treatment in oncofertility. Thank you for your kind attention.